Srinivas Kumar.
Yeah, good evening, sir. Respected chairpersons, my dear friends. Basically, I did discuss regarding this topic with others. When many people didn't show too much interest, I thought I would do it myself. But I feel it is very important for all of us, as sir mentioned, that we struggle for patients so much, but we sometimes fail to take care of ourselves. Very distressing data of recent Kerala registry, I think you know, doctors are dying early. So we should take care of our health so that we can do good to patients. At the same time, we should not be too much worried. So what I would cover in the next 10-15 minutes is basically some of the things which are very important for our day-to-day cath lab practice. This slide brings best wishes from Citizens Hospital. I'm also proud to present our team, FPS, the Fax Professional Services. We are a team of over 27 cardiologists and 3 cardiac surgeons, run services in multiple hospitals with the heart team concept, and then probably each of us help each other. That's how work-life balance also could be managed. And we wish any of young dynamic colleagues who want to join the team, we are always welcome to take care of any of the new entrants. Thank you. And the coming 10 minutes, what I would discuss basically is, we talk a lot about, we hear about RADs, GRAYs, and what are these. Sometimes it is confusing, C-words. So what I would first mention is how do you measure these radiations, what are the various units. Then also tell you about which are the high-risk procedures and what are the regulatory cautions about these procedures. And radiation ill effects, what are stochastic ill effects and non-stochastic ill effects. And then how to keep radiation low. At the same time, the image quality should not suffer. That's what is the LRA concept, which I would briefly take you and run through. And some of the simple things which you can do bedside, which we neglect in the cath lab on the table, which you can decrease the radiation significantly. And some of the newer high-tech stuffs which have come, like CarPath, things like that, I would briefly touch upon and conclude. That's a wish to proceed. So what is important is what the mind does not know, the eyes cannot see. And the reverse is also true. What the eye does not see, the mind does not know. Radiation is something which is happening in the lab, but you're not able to see it. That's why you're not bothered too much about it. But if you see the data, it looks so surprising that all of us should be taking more and more care. This is the physics primer, radiation units. If you're coming to, exposure is measure of ionizing radiation producing in the X-ray. Suppose anything coming into the air, how much is it causing the exposure? That is what is measured as Roentgen units. And when that is exposed and how much is absorbed by the tissue, absorbed dose is what is measured as rads. In other words, SI units, it is called as grays. So 1 gray is 100 rads. But one is finally, after getting absorbed, what each tissue, it has a different effects. So that is what is called a dose equivalence. How much is each factor producing the problem in this? So finally, what we are more important clinically is about sieverts. So that's how we measure CT angios in sieverts and X-ray radiations in sieverts, because that is what is essentially equivalent to what damage this is causing onto the human body. So that is what is about Roentgen, Gray, and sieverts. If you have to remember one unit, probably sievert, you can remember millisieverts and sieverts. Then way back in 1994 itself, US FDA said there are some procedures which are high ionizing producing. There are radio frequency catheter ablations, and the PTCA is also mentioned there. Now it's more relevant because more and more CTOs, complex cases are being done. So it's more relevant in today's era compared to type A type of lesions which you were doing before. Some of these other therapies which are long time-taking procedures, peripheral vascular procedures, are also included in high-dose procedures. So this is important for us to understand how is the radiation, what are the biological effects of this radiation. Sometimes you hear of cancer, sometimes of erythema, what is it? So basically you have the effects divided as stochastic effects and non-stochastic effects. Non-stochastic effects is what is getting immediately. If you have the higher radiation happening, you get erythema, epilation. This is all is non-stochastic effect. Stochastic effects are the effects which happen through genetic changes or happen through cellular mechanisms. In the long term, they produce cancers. That is what is stochastic effects. So what we are immediately concerned is to avoid the non-stochastic effects, but this what we as professionals should be concerned is about stochastic effects. So non-stochastic for patients and stochastic for doctors. Then if you have to know how this is producing, I won't go into too much of pathological details, but it suffices to know that this radiation produces free radicals, and these free radicals produce lot of tissue damage, cellular damage, and each of the tissues could respond differently. That's why the cataract in the eye responds differently, the human brain responds differently. That's how these mechanisms are supposed to be acting, and that's how we need to be careful about it. If you see the various doses which it cause, initially you have a very less exposure, shorter exposure, and lesser dose probably will cause just erythema, skin, understandably so, skin becomes just red. But if you further increase the radiation in timing, probably you will go into the stage of desquamation, epilation, hair loss, and if further not seen, patients exposed further, they will go into the stage of dermal necrosis, atrophy, and then fibrosis, but long-term exposure could lead to skin cancer. So these are some of the pictures. I would can confess that these are not from our lab. I took it from the atlas. Basically, these are the biological effects of basically hair loss, which you see. Then you have burns produced like during the EP procedures especially. Then some of these are also produced during CTOs. This is some when the arm is left, we don't see bother where is the patient's arm kept. If it directly falls on the X-ray generator, sometimes tube, you could produce such drastic damage to hands. We wrap the patient in and the hand goes down below, and if you don't observe and it falls directly on the tube, there is more likely to produce problems. These are some of the various procedures described there and some of the abnormalities mentioned, and these are such sort of ulcerations. One more thing is, if you've done a CTO, you may not see it immediately. When the patient comes for follow-up for a week, then you could notice such sort of ulcerations happening little late also. And then that is about patient's worry. The doctor's worry is we should all understand how much risk we are exposed to. We are worried to take one X-ray normally, but lifetime exposure of doctors, the calculation is that you are exposed to about 50,000 chest X-rays in an average span of about 15 to 20 years of interventional cardiology. That is in fact could lead to 5% risk of generation of cancers. That is your professional hazard for us is about 5% risk of cancer, more than the general population. This study showed that probably in brain tumors, if they have analyzed, because left side gets exposed more, we are more close to radiation, the tumors are 86% more common on the left frontal cortex than on the right. So that's important. This study again recently published in cardiovascular interventions showed that compared to technicians, cardiologists, technicians say they are exposed more, but as we are close to tube, all these problems are more in the interventional cardiologists compared to techs or sisters. Then now that we know what are the problems which can happen to patients and doctors, now let us see how to reduce this radiation exposure. I would like to mention this ALARA concept is an important concept, that is how to maintain the image quality, but the exposure should be less. Suppose if you further decrease totally, you can't see anything. As Dr. Kaparthi was telling, you keep exposing more and more time, that's no good. So we have to maintain the image quality, but at the same time decrease the radiation. That's what we are trying to see. These are the various methods described like intermittent fluoroscopy, removal of grid, image collimation, dose sequence spreading, and all that I would cover briefly one by one. So we need to understand our machines, cath lab machines. How many of you seen when how much exposure is happening? We hardly ever see. We're more interested in outcome, what is happening, but we don't go to the cath lab table. Please go and watch after the procedure is done how much is exposure happening, and all of us should keep some limits after which alarm should come. That is possible only if you work with the tech and see what is happening. One of the most important thing, I think this is most of the machines themselves have come up now, unlike when we were students, is intermittent fluoroscopy technique. You don't continuously, when you are exposing also, continuous fluoro would need not happen. Intermittent fluoroscopy and the image storing and thereby last image hold methods significantly decrease radiation to doctors. And there is something called what is called as grid, which is now initially it was mechanical, now mostly electronic grids. Once it is there, it is basically to optimize the exposure, not to have too much scattering, it is kept in the machine. If it is removed, probably you have less of radiation, but we need to again see in which patients it is required, which patients not. When I was a student, actually I used to think this collimation, why can't it happen once images are taken and then the technician can collimate? Whatever we thought, it has already happened. So previously when we were students, when you have to do fluoro, only the collimations technician has to do it. Now it's not like that, and you can actually take an image and the collimations can be done off of fluoro, and that's how you can decrease the radiation. Dose spreading is another concept. Though you are constantly imaging only heart, it is better to change the angulation, not only for the visualization, it also helps in decreasing the radiation in particular part of the human body. This is what is beam quality adjustments. Basically, it is always important to see the skin and other parts which are more sensitive or to be exposed to less quality, but at the same time image beam too much is decreased, again will leads to loss of image quality. This is again one simple important concept which all the fellows should take it. We keep patients tables in various sites unknowingly depending upon doctor's sites. What we need to see is when the patient is too close to X-ray source here, there is maximum radiation to patient. That means all the doctors who are little shorter have doing more damage to patients as also more problems to ourselves. Simple to remember. The lower the patient placement, the more closer to the X-ray tube, the more is the radiation. On the other hand, if it is here, it's more closer to image intensifier, the radiation is less. That is, taller doctors probably give less, just for your remembrance. So it is always, you can always adjust the height of this also too. I'm just jokingly saying taller and shorter, but the closer the tube to the patient, the more problematic and more radiation to the patient. It's important. And we need not ignore it, because it is supposed to be, the figure doesn't come up well there, but it's supposed to be 3 times the difference. Somewhere it is middle, compared to this, the radiation is 3 times in this position compared to the other positions. So another thing is image magnification. All of us have the habit of keeping higher magnifications. Though it is required whenever particularly you are seeing for stent imaging and things like that, it's not advisable to have higher magnifications always. Why? You see here, if you go to the higher magnifications, again the dosage, not only the quality improves, but again radiation goes up 3 times, more than that. So probably what you are comfortable in routine angiograms, probably you can do with a lower magnification, non-mag, and single mag and double mag, only use it when necessary. Dose level settings, again we need to work with each of the systems. Philips or some of these have those things set in compared to low, medium and high dose levels, and probably you can adjust those settings depending upon the patient. Luckily to us, this latest machinery, it selects by itself in auto mode. Then pulsed fluoroscopy, this is very important, especially when you are doing long procedures like CTOs. You need not have a continuous fluoros. Even if you are doing continuous exposure, the frames pulses per second comes only intermittently. Normally, the average what we use is 15, but if you have very faster heart rate, tachycardias, pediatric patients, we tend to go up to 30 frames per second to have the better image quality. But you have to understand the radiation is more here. And if you are doing CTOs where that image quality is not, that much is not required immediately, just to have to see how the wires are crossing, then probably you can go to lower frames per second. Generally we keep around 7.5. So this again significantly decreases the radiation compared to the regular frames which we use. Then coming to what we can do, what all I told is regarding the machinery adjustment, cath lab adjustments. We as clinicians also should be taking care of ourselves, of radiation safety. Many of us walk in without proper shields to us, and radiation level exposure significantly is more if you are closer. But if you are far off from this thing, again from the field, need not worry. If somebody is 6 feet away, the radiation is much less. 3 feet away is 1 by 1,000th of a field of a closer person. Then this Alara concept also goes on to say what all other things regarding the positioning of the tube, and I will explain this by these pictures. If the lead drapes, how many of you use these lead shields? Nowadays, when you are doing the live cases, when Antonio and Aberard were using, they were very particular that you have to always use that lead screen. But we inadvertently think it comes in way, we are not in practice of itself, we don't use it, but it's recommended to be used. Lead drapes, again, decreases the radiation, and then if a radiation shadow shield, this is what I was talking of, if it's kept, it is always better. And this is, rather than this thing, I will show you the picture. If this is closer, that's what I said is bad for the patient. And then regarding the RAOs and LOOs, viewing, if a patient, this is the X-ray tube, if operator is here, obviously you get more exposure. If you have to take probably lateral views, you don't keep this away on the other side. Then same thing, this is the image intensifier toward your side is better, X-ray tube on to the opposite side, lateral C-arm. And regarding the positionings, cranial views again will be bad because this image intensifier, this radiation source comes more closer to you. Probably RAOs are better to decrease the radiation. So this is how we need to shield ourselves and probably position it, and we see how best we can keep. Then other important things which are coming up is whole body exposure limits. Rather than dwelling on it, for the sake of time, I'll just briefly mention about these radiation dosimeter badges. Many of us are reluctant, don't wear our badges properly, but it's important for us to understand what it throws, and this is a sensor which has exposure radiation. It has to be sent to relevant authorities once in 3 months so as to avoid, and it has to be placed. How it should be placed is basically in the era of selfies. I took a picture myself keeping it inside. Normally if you put it outside the X-ray shield, the protection radiation thing, obviously radiation will be more. Keep it inside, and then if you have to still monitor yourself, you can have one more wrist badge, what is recommended, to see how much exposure is happening. It's important for us to keep it when during the procedure. Another important thing which initially, which I was reluctant, but later on when I saw, is bismuth-based aprons. We normally see lead aprons which are very heavy compared to bismuth. Bismuth aprons are very thin, but protection is slightly more and slightly expensive. If somebody is doing regular procedures, you can go for bismuth-based rather than lead aprons. The rad pad, initially when it came, I did not believe that it protects so much, but we ourselves have seen in the lab with nuclear medicine dosimeters coming, and surprisingly with the principle when it is covered like this for radial procedures especially, there is significant decrease in radiation, and this is what we demonstrated live to in TCT live conference, but it has gone up by 60% just by application of the rad pad. We reuse that too. Then zero gravity radiation protection is another thing which is coming up, where it is all hanged from the top, and then you just go and the magnet sticks to it, but unfortunately the company keeps it at a very prohibitively high cost. That's how it is. You just go from behind and you don't wear anything. Everything is radiation protection, and these are some part-time modifications are also coming up now. It's not ceiling mounted, but such sort of things with wheels are also possible. So conventional compared to those what we wear, these suspended ones are also proven beneficial, and radiation is supposed to be less. This coming to end, this high-tech thing, this car path where totally robotic assisted PCI is, they say it is decreases significant radiation. Obviously, definitely it has to be, because you are not going closer to the X-ray machine. But there is other advantage in our, which is more relevant in our country, I feel, is you can control the arm through internet, and probably a days could come where the facilities, cardiologist is not available. By this technology, we could actually do procedures, relatively straightforward procedures at least, in a guidance through using this equipment. So this study showed that robotic assisted PCI decreased 95% radiation to the operator. So, but again, having said all that, what I feel is rather than dwelling too much and thinking too much about radiation, not entering the lab, I think we should follow these precautions which mentioned, and probably all of us, we need to follow these ALARA principles and practice medicine and do good to the patients, for needy patients, and that's how we be happy and our patients will be happy. Thank you very much for patient hearing.
Thank you, Dr. Srinivas. That was a very elegant lecture.
Thank you.
The Philips Clarity systems, they claim that there's a 75% reduction in the radiation. So.
And all the systems have radiation reduction. They call it, one calls Clarity, other call it by some other name, Care or some other.
Yeah, but this they specifically claim because there is a copper grid during both fluoro as well as cine.
Yeah, compared to before, earlier systems, they're much better less.
And one radiation. Simple question: where exactly should you place your dosimeter? Is it over the lead apron or?
I showed that picture. That's why it is basically whatever dress you are wearing, to that packet you put it, so that you cover it with the lead apron.
Cover with the lead apron.
If you keep it outside, definitely radiation is much more.
We have to use two sometimes.
Yeah, that's what I mentioned. If you're too particular, you want to measure one, there's one thing called wrist dosimeter also available, or you can put it onto the collar above, but definitely you get higher values. But what all is recommended is for the dosimeter within.
Okay. Srinivas,
sir.
Thank you very much for the nice lecture. How do you measure sieverts? I never understood it.
Actually, you came little late, sir. I covered that.
No, how do you measure it? Sieverts. We know that the concept. It is the radiation dose absorbed by the body. No, but how do you measure? How do I know how many sieverts radiation I received?
That is what, it is each of it, it comes on the machine, that there's no way you can see it. That's the problem of grays or sieverts or this thing. So you will know when you are taking X-ray how much has gone inside,
That
machine
comes
gives it.
on the screen? I don't know.
This grays come on the screen.
But
And
sieverts?
each of it, when it is coming, I think this calculation, something could happen. There is no direct way by which.
No, sir, Dr. Shastri, actually we have done so much this one. The thing is, Ekurma is important, which will be displayed in the machine. Ekurma, that is called. That is exposure radiation. Then the absorbed one is dosimetry, actually which.
This one, what we measure, I think.
Yes, correct.
What we measure here.
We have seen with the rad pads actually, without rad pad, just exposure, your absorbed dose is very, very high actually. With rad pad, almost 95% absorbed dose is less.
I have
Very
seen-
peculiar. REMS actually, with the average one angioplasty, a straightforward angioplasty if you take, of around some half an hour angioplasty procedure, with a Ekurma of around, it will be say in milligrays actually. The absorbed dose is around 5 rems or 4 rems.
Yeah.
But which is an ideal, what they told. But with the rad pad, once we used it for the patient and all these, the bismuth salt rad pads, almost it came to almost 0.3 rems and 0.2 rems.
I personally checked with nuclear medicine thing, it decreased by
Actually,
75%.
this was dosimetry we have to calculate.
And I think
And
One
one,
question is, what is sievert? How do you calculate sievert? That's what his question is.
No, the-
Sievert.
What is absorbed by the
It's
dosimeter?
absorbed
when you
dose.
commit,
It is
it
absorbed
comes.
dose by the
that
body.
comes
is
only, we can't measure it, if I
can't.
understand.
Yes.
The badge when we send to the nuclear
Dosimetry.
medicine people,
Yes,
they
correct.
give the,
Yes.
we can't measure it.
Yes, exactly.
We
Exactly.
have to roughly go by
Yes,
the
yes.
radiation like REMS and grays.
As per the recommendations also, if the display which was seen, if a cumulative dose or even one single procedure, suppose prolonged procedure, if it reaches 7 grays,
yeah, 7 grade.
then you have to stop the procedure.
You can
That is all.
keep the alarms in our
Yes,
cath
yes,
labs.
correct. That
so
is
it
as per
stops.
recommendations.
And then immediately what can be used is the placement of C-arm, how it is done, and the keeping away from the X-ray source, and then keeping the heights of the table to be adjusted. And then some of those things looked very simple to me.
Yeah,
And then
extreme- avoiding extreme
frames per
angulations.
second adjustment, those are things which
And
are
the
to
lead
be,
aprons
which can
get
be.
damaged, when you put it just like that, without properly hanging it.
Yeah.
Even otherwise also
once
the
they
lead gets
develop
damaged,
cracks, then of
cracks.
course,
So
yeah.
I think after 1 year, the aprons have to be changed, or you
Yeah,
should
if it is
Another
broken-
request the
important
management to
another
change the
important, madam,
aprons.
lead caps is nowadays available.
Yeah.
You have
Even
to wear the lead caps.
Those tumors
Yeah, that
of
we are using.
brain
Bismuth salts,
may be more
most
common
important.
if you don't wear it. So lead caps also, we could wear those caps.
So.
Recently in one of those
we'll
meetings they
take
have
this
distributed.
opportunity
Yeah.
to thank all the speakers for wonderful presentations.
Yes.
Hello, hello.
And I also thank the
Hello.
audience for having so much patience and participation. So we conclude
Hello.
the session.
Hello,
Thank
sir,
you.
just one minute. Actually, on internet I saw one video, sir. They are real time showing the radiation exposure. So suppose the primary operator is bending at the time of procedure, exactly the value it is showing. So how much it is in use, I don't know, but it is available on, like, information is available.
Yeah, primary operators always get more radiation.
No, no,
than
but it is showing real time,
I
sir.
think radial it is
Real
more
time
than
it is
in
showing.
femoral.
Okay.
Radial operator more exposure compared to
Yeah,
femoral
radial
operator.
more exposure. That's also slide was there.